What are your criteria if you're using topical beta blockers or oral propranolol? What are your criteria for initiating it? So how do you determine that we should start it?
Well, for periocular hemangiomas, if they're greater than 1 centimeter in size, or if they're obstructing the visual axis, if they're causing a lot of induced astigmatism, I think we're pretty quick now to initiate treatment. I work with a very strong dermatology group, and I find many of the patients actually show up to my office already taking propranolol. So I'm often not the one who makes the decision.
So I think in my institution, they don't wait until you have one of those parameters. If they see any hemangioma on the eyelid, they're going to start treatment very aggressively.
I see. So often they're coming to you after they've already started treatment?
Yeah, they're usually referred by the dermatologist after.
Yeah, I'm finding the same for me.
Yeah.
And then has it been anyone's experience, the audience is asking, when oral propranolol is insufficient or they're refractory to treatment, do you couple it with something else? Or has it been your experience that the beta blocker is always effective?
It's not always effective. It's effective the majority of the time, but there are certainly cases where the beta blocker doesn't work. We had one recently that they were very concerned that maybe was not an infantile hemangioma because it did not respond to propranolol at all. But it had other characteristics that were quite typical for an infantile hemangioma. It started out very small, grew very rapidly in the first couple of months of life, and eventually this patient went to biopsy, and in fact it was biopsy-proven infantile hemangioma that did not respond to propranolol, and steroids were initiated, and it responded nicely to steroids. So you have to keep these other tools in mind.
I think that's exactly correct. I think we see a very strong cytoreductive effect from propranolol. It's not 100% effective, although the effect is usually very profound, but it really facilitates a much smaller surgical intervention on the adnexa when we need to do some sort of reconstructive effort. So we really try to push it as far as we can prior to considering any other modality.
Can you elaborate a little further on that? So
Sure.
What would be your threshold for surgery?
Often it's really more of a cosmetic issue at that point. The lesion is stabilized, the parents aren't comfortable with the appearance, the degree of astigmatism may be perfectly stable. According to my pediatric ophthalmology colleagues, we don't measure these things in oculoplastics. But at that point, we can start to talk about quality of life issues as compared to simply, vision threatening or, orbitally disfiguring disease. We really have a much different discussion thanks to this medication, I think.
And is it the panel's experience that you're guiding the tapering protocol, or is this really driven by your collaborators? So are you telling your collaborators now it's this size and therefore we should initiate a taper? How is the tapering done?
Sorry.
Yeah. My institution, the dermatologists basically drive the decision about treatment and when to stop treatment.
In ours too, and it usually requires treatment for at least 6 months, and when you discontinue the propranolol, they can rebound, so sometimes they have to continue the treatment longer.
And has there been experience with recurrence of the hemangioma on this taper, and how is this addressed typically?
They definitely can recur when you taper, and sometimes you do have to reinstitute the medication and taper it over a longer period of time.
I'll ask a question of the panel. So if they're smaller, I would start topical timolol myself, and if they grow or if they're larger, I would refer it, and they're managed by dermatology. Working with Lois Smith, she started this topical treatment a long time ago, and she would ask parents to massage timolol in with every feeding, which is pretty frequent. And I know now many people do only twice a day. So I'm wondering what you all think about frequency of topical.
I don't have too many thoughts on it, but you did bring up another point that I wanted to raise to the panel as well. Anybody else have?
We honestly don't use a lot of topical. I think orals become the mainstay at my institution.
Does anyone have any concerns about the long-term neurodevelopmental effects of propranolol on children, similar to the way we concern ourselves about Avastin? Because I think that has been raised as a concern, and I think there's been, similar to Avastin, there's some limited evidence that it's not causing any problems. But I think, it's funny how we're so concerned about that for Avastin when we use it for ROP, but this treatment also has the potential to interfere with neurodevelopment and doesn't seem to be as big of an issue.
Any thoughts before we move on?
Well, that's maybe another reason to try the topical if you can. The topical can be very effective.
But it also can have side effects, too.
And I think the literature supports that there is more rebound effect with discontinuation of topical as compared to the oral.
Okay, so there's still a lot of unanswered questions about
lot of unanswered questions about all of it.
hemangiomas. So stay tuned.